The recurrence rate of chronic subdural hematoma after surgical treatment is high at 20%, and middle meningeal artery embolization to treat chronic subdural has emerged as a safe and effective strategy. Chronic subdurals are thought to be due to inflammatory neovascular membranes with a propensity to repeatedly use. These thin-walled capillaries don't have smooth muscles and have multiple endothelial gap junctions and vascular supplies from the middle meningeal artery. Embolizing the middle meningeal artery breaks this repetitive cycle of microbleeding and inflammation, and the embolic material penetrates these neovascular membranes, accelerates reabsorption of the clot, and prevents repetitive bleeding. More than 90% of the subdurals resolve with just middle meningeal artery embolization, with only a few as low as 4% needing surgical rescue. Indications for middle meningeal artery embolization. If the patient is mildly symptomatic or asymptomatic, it can be used as a standalone therapy. In severely symptomatic patients who are high-risk surgical candidates, it can be used as a standalone therapy, or a pre-evacuation MMA embolization can be performed. This is a patient who had previously ruptured ACOM aneurysm and a chronic subdural which was asymptomatic. The plan was to coil the aneurysm and do middle meningeal artery embolization. This is the initial injection from the middle meningeal artery posterior division, which shows highly vascular subdural space. These are the neovascular membranes that develop due to repetitive bleeding and inflammation in this space. Thereafter, we navigate the microcatheter to a location as distal as possible and close to these neovascular membranes. Repeat injection clearly demonstrates these neovascular membranes, which are the reason for these chronic subdurals. Note the injection of the liquid embolic agent SQUID12 here in order to allow permeation into the neovascular membranes. There are groups that have used PVA particles as well as glue. Liquid embolic agents are likely to offer permanent cure as opposed to PVA particles. Now we will show the native image which shows the SQUID12 in the middle meningeal artery branches. Following the injection, the marathon microcatheter was removed. The post-procedure injection shows clearly absence of these neovascular membrane enhancement. There was near complete resolution of the clot in 8 weeks.